This is the ophthalmology section. I'm Conrad Fisher, Associate Professor of Medicine, Pharmacology, and Physiology at Touro College of Medicine and Director of Educational Development at the Jamaica Hospital System in New York City. You will have everything you need in this section to cover all the questions you'll see on ophthalmology for Step 2. You do not need any other sources. You'll see all the images you need and have all the information you need. It is more than complete. How do I tell the difference between viral and bacterial conjunctivitis? Viral conjunctivitis spreads enormously easily. A simple touch. It's why you can't share pillows, towels, pillowcases, washcloths. A simple touch will spread the virus from one eye to the other and from the eye of one person in the household to another person. Whereas bacterial conjunctivitis is unilateral, doesn't spread, doesn't transmit between people. It's a watery discharge in the viral conjunctivitis, whereas it's purulent, thick, nasty discharge in the bacterial conjunctivitis. The viral conjunctivitis, amazing, simple inoculation with a little touch, whereas bacterial conjunctivitis is limited to that one person. Neither of them should affect vision. They're simply inconvenient. Now, viral conjunctivitis also has itchiness and also has lymph nodes both in front of your ear, between your ear and the angle of your jaw, whereas bacterial conjunctivitis just doesn't go into the lymph nodes. There's no specific therapy for a viral conjunctivitis. It gets better on its own. We don't have an effective antiviral for that infection, whereas any topical antibiotic can work for bacterial conjunctivitis because when you use an antibiotic topically, you can give it at a concentration that would otherwise be too toxic for systemic use. For instance, that's why medications such as gentamicin, which for bacteria systemically might cause renal failure, topically for conjunctivitis is totally safe. So we're not going to spend a lot of time making you learn too much about specific bacterial antibiotics here, because the whole point is to be able to recognize it's bacterial so you just know, hey, this person does need some topical antibiotics, that's all. So how does it look? Viral conjunctivitis makes that eye red and watery, whereas bacterial, you could see, makes a much more thick, disgusting, nasty discharge coming out instead of a thin, watery one. Now, the must-know subjects that you have to have for ophthalmology are the red eye, what are the emergencies, the diabetic retinopathy, artery and vein occlusions, and retinal detachment. These are the biggies. That's what you need to know. Those are the top 5 images for you. Bacterial conjunctivitis is going to give a presentation of the discharge, and the eye finding is going to be that there's normal pupils. That's a biggie. It's almost exclusively a clinical diagnosis. We rarely will culture the person's eye, and the therapy for this is topical antibiotics. Now, uveitis. How are you going to answer the question, what's the most likely diagnosis? What's different? Well, one, the history of autoimmune diseases, but on presentation, photophobia. You might be surprised to know that conjunctivitis doesn't really give visual findings, but conjunctivitis doesn't give the photophobia of uveitis. See, uveitis is like nuchal rigidity. You see, anything that moves the uveal tract, the uveal tract is a $5 word for the iris. So when that iris constricts and dilates, it causes pain. So like moving your neck when you got meningitis. And the slit lamp exam, basically a large magnifying glass to look at the iris, will show you who needs topical steroids. Now, in general, we're not crazy about just using topical steroids in anybody, so that's why I want to use that slit lamp to know for sure, hey, who's really got the uveitis? What's different about glaucoma? Well, one is pain, but a lot of these could be painful, as well as, it's pain with a fixed midpoint pupil, because glaucoma, that pressure is squeezing the iris against the cornea, so it forms something called synechia. Wow, there's an expensive word for you. Synechia means a stuck pupil. It's fixed in the midpoint. It's not dilated, it's not constricted, in the middle. And that's how you know to get the tonometry. What's going to make you get the tonometer, the Schiatt's tonometry, is a fixed midpoint pupil with the red eye. Now, we use a number of things for acute angle closure glaucoma. I want to be clear, this is acute angle closure glaucoma. Acetazolamide blocks the production of aqueous humor. Mannitol acts as an osmotic diuretic in much the same way as we'd use mannitol for a person who has a subdural hematoma to decrease pressure acutely. Pilocarpine constricts the pupil, and when you constrict the pupil, you open the canal of Schlemm. And if these things don't work, and we also can put some beta blockers on there like timolol, laser trabeculoplasty means poking a hole in your iris with a laser to increase the drainage. The last part of this is that we can use some prostaglandin analogs as well. Latanoprost and prostaglandin analogs, more so in chronic disease, helps increase the drainage of the chamber. Abrasion always comes with a history of trauma, the most common trauma of which is the use of contact lenses. It feels like there's sand. Matter of fact, it's extraordinarily uncomfortable. It's more like rubbing sandpaper on your eye. The fluorescein stain gets picked up where the normal corneal epithelium has been removed. And then ultimately, unfortunately, patching really doesn't help. It doesn't. And if it's from a contact lens, patching is actually contraindicated. It's not clearly beneficial to anybody, and it's contraindicated when you've had it with contact lenses because of the bacterial colonization. Chronic glaucoma is much more often asymptomatic. That's why it's got to be screened for. All older people should be screened for glaucoma. Glaucoma worldwide is one of the 2 or 3 most common causes of blindness because we don't have screening methods in the rest of the world. But for us, when we're screened, we find it before it's damaged, the eye. You confirm it with tonometry, and you find the elevated intraocular pressure, and you can treat it and really fix it before it damages the eye. There's so many options now. The treatment is to decrease the production of aqueous humor or increase the drainage. Prostaglandin analogs like latanoprost and travoprost and bimatoprost, prostaglandins, increase the drainage. Topical beta blockers also increase the drainage and decrease production. Timolol, cartiolol, metoprolol. These are all things, well, you may say, wow, I've never heard of those alols. Well, these are not ones that we use for cardiology. That's why timolol is not one we use in cardiology. These are the ones like betaxolol or levobunolol. These are all very much ocular beta blockers. That's why. Now, topical carbonic anhydrase inhibitors like dorzolamide and brinzolamide decrease the production of the aqueous humor. They decrease production if they were used systemically. They would be things that you would use for pseudotumor cerebri. But topically, remember, we can use things topically that we could not systemically. It allows really effective therapy. Look at all the cool stuff. None of these things really were used more than 25 years ago, and that's why the blindness rate down from glaucoma is down by so much. Alpha-2 agonists open up that canal of Schlemm, like apriclonidine. It's a great drug. Opens up the canal of Schlemm. Pilocarpine has been around for a long time, and basically pilocarpine increases acetylcholine. It increases acetylcholine, increases the drainage out of the eye by increasing acetylcholine. And finally, if all the medications won't control it, we can use a laser where we set the focal length. The focal length will actually burn through the iris so that it allows you to just knock a little hole there. It actually goes through benignly through your cornea, and it creates heat and damage just at the level of the iris and increases the drainage. Isn't that great? In acute angle closure glaucoma, you're looking for the sudden onset of it, extremely painful. It's excruciating. You've got like your eyeball's going to explode. It's red-eyed. It's hard to palpation. And walking into a dark room makes it get worse because in a dark room you get pupillary dilation, which blocks the drainage even more. The pupil just doesn't react to light because it's stuck, but if you're in a dark room, it wants to react, but it can't. So it's really very, very uncomfortable. A normal cup to disc ratio is 0.3. In other words, the cup is in the disc like a cup in a saucer. And the normal ratio is 0.3 or less. 0.3 or less. So in glaucoma, you'd see it above 0.3. This image is trying to show the hazy cloudiness that you would get with acute angle closure glaucoma. It's a hazy cloudiness from the increased intraocular pressure. And what you see is conjunctival vessels dilated at the corneal edge. Wow, look at that. Cool image, huh? And a hazy cornea. Whew. Gives me chills, that image. I like that. The diagnosis is confirmed by putting a tonometer right onto the eye and treated acutely with an IV acetazolamide, mannitol to increase the osmotic drainage, pilocarpine and beta blocker constrict the pupil, enhance drainage, and ultimately poke a hole in that eye with a laser if those things don't work. Herpes keratitis. Well, keratitis is the word for infection of the cornea, so we don't use the word corneitis, I suppose. The eye is going to be described as red and swollen and painful. It's going to make it look like you really want to, please let me use some anti-inflammatories like steroids, but don't do it. Don't do it, because steroids, they markedly increase the production of the virus, the growth of the virus, like throwing fertilizer on it can actually blind people. Wow. The fluorescein stain will confirm the dendritic pattern of damage to the cornea. So instead of using steroids, which can make it worse, even though you're dying to because it looks so red and swollen, you basically treat it like you would any other herpes infection in the sense of oral acyclovir, famciclovir, or valacyclovir. But we do have something new for you here, a topical that used to be used 30 and 40 years ago systemically, but we only use it topically now. Basically, trifluridine and idoxuridine. Trifluridine and idoxuridine have now become one disease drugs. These are only for herpes keratitis. That's it. Beware of that steroid use because steroids will make it worse, and you could use standard anti-thymidine kinase inhibitors like acyclovir, famciclovir, valacyclovir, thymidine kinase inhibitors, or topical trifluridine, idoxuridine. There is no medical therapy for cataracts. The therapy is surgical removal. Surgically remove that lens, you can suck it out, and you can replace it literally with a new intraocular lens by actually make an incision. It takes 4 or 7 minutes. You can use a little vacuum cleaner and actually literally suck out the lens and put a new one in there that has an instant bifocal. So your mother goes into the operating room wearing thick glasses. She comes out, not only is her cataract removed, but she can throw her glasses away. Early cataracts are diagnosed with an ophthalmoscope or slit lamp. And advanced cataracts, you can just simply see them. They look white. Like this. You can see it when it's so advanced. Wow. One of the 3 most frequently asked ophthalmology questions is making sure you know for sure that all diabetics need to have their eyes screened. Type 2 diabetics, you just don't know how long they've had their diabetes, so you're going to start screening them right away. And you've got to detect that retinopathy before the visual loss occurs. The visual loss happens because the distal parts of the retina become starved for oxygen, and they send a chemical signal to the proximal portions and say, okay, send us some blood vessels. We're starving out here. But the problem is that those extra blood vessels, you just can't see through them. So once it starts to proliferate, you got to zap it with a laser. Now, non-proliferative or background retinopathy, little dots and blots, little hemorrhages, managed simply by controlling the glucose level. We don't have anything else for that. The most accurate test is fluorescein angiography to see the proliferation of the vessels. And proliferative, meaning neovascularization or vitreous hemorrhages, neovascularization or vitreous hemorrhages gets laser photocoagulation. The vascular endothelial growth factor inhibitors, the VEGF inhibitors, bevacizumab, ranibizumab, bevacizumab, ranibizumab. Well, it's an amazing thing. These drugs were originally used and developed as chemotherapeutic agents to stop cancer growing. And now they are the drug that stops macular degeneration, and 97% stops macular degeneration and can stop the growth of proliferative retinopathy. It's a miracle, man, a miracle. Vascular endothelial growth factor inhibitors are injected directly into the eyes of some patients to control that neovascularization, and actually can reverse it in some people. Wow. Vitrectomy means you're removing the vitreous chamber. And the problem with the proliferative retinopathy is if you get a Vitreal hemorrhage as part of proliferative retinopathy essentially will blind you. So if you have proliferative retinopathy and you have a vitreal hemorrhage, you physically can't see anything. You got to get rid of the vitreous to restore vision. So vitrectomy may be necessary to remove the vitreal hemorrhage that's obstructing your vision. Retinal artery and vein occlusions are must-know for you for this test. Both present with the sudden onset of unilateral monocular visual loss. Both need you to look in the back of the eye. And unfortunately, there's no conclusive therapy. Now we can try thrombolytics for artery occlusion, try oxygen and aspirin massaging the eye, but there's nothing proven for either of them. But you have to be able to make the diagnosis. You have to be able to know it's not detachment, that it's not something you can fix otherwise. The retinal artery occlusion is a pale eye. The macula appears dark because the rest of the retina is pale. It's pale because it's been blocked off. It's the same as any other artery occlusion. Now, the first branch of the carotid artery is the ophthalmic, and unfortunately, when you send an embolus up there, unfortunately, unlike a stroke, we don't have anything really good to reverse it. The retina is pale. The macula appears dark. Now, the macula is where all the vision occurs. 99% of the vision is in that 1% there with under the arrow called the macula. And the problem is, though, when it gets starved for blood and it dies, you can't bring it back, and that's unfortunate. Now, unlike the previous image, this is one that's filled with blood because the blood got in, but it can't get out. That's how you know it's a vein occlusion. The blood gets in, but it can't get out. Blood gets in, just can't get out. Now, we want to make a distinction between what should you use for treatment versus what is clearly proven. There's nothing clearly proven for either of these. What is the treatment you should attempt? Treatment of arterial occlusion is attempted with 100% oxygen, acetazolamide to decrease intraocular pressure, thrombolytics to try and unclog that artery. But it's not clear. The macula is not exactly more red than it used to be. It's described as cherry red in artery occlusion simply because the rest of the retina is just much more pale. So as dissatisfying as it is to try and treat artery and vein occlusion, retinal detachment is much more satisfying because we can actually fix this one. We can get that detachment back. It's caused by trauma, literally knocking the retina off the back of the sclera. Extreme myopes actually make the shape of the eye a little oblong. And that changing the shape of the eye with extreme short-sightedness, nearsightedness, puts more tension on the retina, actually pulls it off. Same as diabetic retinopathy, actually scars it up and pulls it off. Anything that pulls on the retina can detach it. It presents with the sudden onset of painless unilateral loss of vision and can be described as a curtain coming down. This is a very important description because this is something that you can do something about. This is something that it's Friday night at 9 o'clock and you've got to know what's in there, so you get that ophthalmologist in there Saturday morning to reattach that retina. Now, the reattachment's by mechanical methods. You can sew it on, freeze it on, laser it on, get an expansile gas which you inject into the eye. It literally pushes the retina back up and against the globe of the eye. But getting it physically pushed back on so that it will reattach can save somebody's vision. Macular degeneration, next disease, our most common cause of blindness now in older persons in the United States. It used to be diabetes, but we've gotten so much better with the diabetes management that the good news is this is now the most common cause of blindness. It's idiopathic. We just don't know what makes it die off. There's two types, an atrophic type or a neovascular type that's wet. We could describe it as dry and wet. And it really has to do with how many blood vessels are growing back there. If there's a lot of blood vessels, we call it wet, neovascular. It's very much more common in older persons, very rare in young people. It's bilateral, and the outside of the eye looks totally normal. But you go blind. Well, it's a very interesting thing that most of the things here that look normal from the outside will blind you the most, such as artery and vein occlusion or macular degeneration or detachment. But you've got to recognize this one so that you can know who can be treated, because we have VEGF inhibitors, ranibizumab, bevacizumab, which will stop it. 99, 97, 99%. The neovascular disease is the one we can treat the best. So it's more rapid and it's more severe, and new vessels grow between the retina and the underlying Bruch's membrane. And the neovascular wet type is the one that causes most of the permanent blindness. So it doesn't matter whether it's less common, it's more common as the cause of blindness from macular degeneration. Atrophic macular degeneration, the dry type, doesn't have a proven effective therapy. But on the other hand, it doesn't cause most of the blindness. The wet type does. What you see here are these drusen, and the drusen are simply a sign of the macular degeneration accumulating there. The best initial therapy for neovascular disease is the miraculous medications, vascular endothelial growth factor inhibitors, ranibizumab and bevacizumab, found by accident while we were treating people's cancer to stop their blindness. Not only do they work, can be injected every couple of weeks directly into the vitreous chamber, but it will stop 90, 97%, and reverse some too. That's way cool.